We'll transition to our next speaker. So as I unshare my screen, I'll ask Dr. Edmundowicz to go ahead and share his slides. So Dr. Edmundowicz, we're so happy to have him round out our conference this afternoon. He's a professor of medicine at the University of Colorado and our chief of gastroenterology, recent president of the American Society for Gastrointestinal Endoscopy. And we are all really excited to hear Dr. Edmundowicz's take on the most recent published Multi-Society Task Force Polyp Surveillance Guidelines. Dr. Edmundowicz, thank you so much for being with us today.
Well, thank you very much for the invitation. Congratulate the course directors for a really fabulous course so far, and I hope the attendees have had a good time today. I can't see if I'm in presentation mode or regular mode. Does it look okay to you?
It's perfect. Thank you, Dr. Edmundowicz.
Okay, great. Thanks. So it is greatly a pleasure to be here. It's a pleasure to be part of this division and to watch all the wonderful lectures today. I thought everyone did just a fabulous job. And I really want to thank the attendees for staying with us for this length of a meeting, and also for the sponsors, because without this, we certainly could not have made this possible. I have a few disclosures. I don't think any of them are really related to this lecture, but I want to share them with you as well. I learned a little bit about the Division of Gastroenterology preparing for a couple of things this month, and one of them was the fact that there is a long history of management of adenomatous polyps and colon cancer in this division, and probably two of the most prominent clinical features have been that physicians of Joel Levine and Dennis Ahman. And I just wanted to highlight that Joel has retired from clinical practice at Denver Health.
Dr. Edmundowicz, are you advancing your slides?
I am, but I guess you're not seeing them go forward?
No, we're still on your title slide.
Let's see. I'm sorry.
There you go. Perfect.
There we go. I'll do it this way. So these are my disclosures for the lecture, and this is I guess the article, or one of the highlights of our division, were the two individuals that put this together were Joel Levine and Dennis Ahman. And earlier this week, we had a lecture on public health policy in honor of Joel as he retires from Denver Health. And it was really a touching lecture, because not only was it given by his niece, Dr. Mandy Cohen, who's actually the director, or the Department of Health director for the state of North Carolina, but it was also a tribute to Joel in the fact that many of us previously didn't realize that he was actually critically important in the work that got a colon cancer screening benefit for most Americans. He had served as a public policy fellow, Robert Wood Johnson Fellow in DC, and actually had become the chair of the AGA's Public Policy Committee around the time when colon cancer screening was being promoted and discussed. And then he became the chair of the Board of Regents for the American College of Physicians, which put him in a position to actually push for colon cancer screening benefits for all of us. So we really do owe Joe a true debt of gratitude for helping us, and for helping us reduce the impact that colon cancer has had in this country. And then we've already talked about Dennis and how important his role has been in the development of our guidelines and policies regarding colon cancer and hereditary colon cancer. We hope that you'll be able to join us later this month for his second annual lecture. And we're going to miss him critically, not only at Grand Rounds, but in our division. Fortunately, we have his protege, who you just heard, who is a fabulous expert in this space, and I want to recommend that you pay attention to her career, because she is also the newest member of the U.S. Multi-Society Task Force on Colorectal Cancer, and I'm sure we'll be hearing more from Swati in the years to come. So my task today is to talk a little bit about this update in colon cancer polyp surveillance. And since 2012, there's been a significant amount of new evidence that's brought us to change these guidelines. And these guidelines are reviewed critically every year, as particularly for new evidence. But they are really brought to us as a updated guideline when there's enough evidence to change the way we manage colorectal cancer. What I also want to talk about is what is expected of your practices and of the endoscopists to follow these guidelines, because it's become very clear and it's been very nicely described in the guidelines in 2020, that we are really a major portion of making these guidelines effective. We have to ensure that our patients have excellent preps. We have to be able to get to the cecum 95% of the time. We have to have high adenoma detection rates. And as you heard from my colleague, Dr. Hamad, we have to have complete polyp resection techniques that allow us to make sure that the adenomatous tissue has been removed. And I'll go into this in a little more detail near the end of the lecture. Now, for those of you that have read the guidelines and understand the definitions that are posed here, I just want to highlight them for you. We're really talking about guidelines for patients that are of average risk of colorectal cancer, so not the patients that Swati was just speaking of, but those that are really at no increased risk of developing colorectal cancer who have a screening colonoscopy. They define normal colonoscopy pretty typically as one that finds no abnormalities. And then to understand the categorization of high risk and low risk adenoma, it's easiest to look at an advanced adenoma or advanced neoplasia. An advanced adenoma is one that's more than 10 millimeters in size, has either tubulovillous or villous histology, or has high-grade dysplasia. If you add neoplasia to that, you can find colon cancer as well, so colorectal cancer. That puts you in the high-risk category, whereas if everything below that is considered low risk, and that's typically 1 or 2 non-advanced adenomas less than 10 millimeters in size. The size cutoff, though, what many of us think is arbitrary, has actually become very important in understanding low risk and high risk, and we can use size and measure size fairly easily during procedures, either using an open biopsy forceps, which is 9 millimeters in diameter, or a 10 millimeter snare and show that your polyp is larger than that. That would put you in a high risk category. Now, the reason this is so important, and I'll go into more detail about the literature that supports this, but if you look at this graphically, it's pretty clear that patients that have either no adenomas on a screening colonoscopy or 1 or 2 small adenomas, less than 10 millimeters without any of these high-risk features, have a very low incidence of developing neoplasia in follow-up. Whereas if you have a high-risk adenoma, any of the characteristics I talked about, or more than 3 adenomas less than 10 millimeters in size, your incidence of actually having a neoplasia or a high-risk adenoma or another adenoma in follow-up is much higher. And so many of the societies have focused on screening and surveillance or surveillance of that population at a higher interval than you would for individuals that had no or a few small adenomas, 2 small adenomas, excuse me. So what is some of the evidence that supports this? Well, clearly there's good evidence now that shows that colonoscopy is very protective. And if you have a normal colonoscopy, you may actually have a durable risk reduction for colorectal cancer that can last up to 15 years. So this was a New England Journal of Medicine publication after the last set of guidelines were published that shows that normal colonoscopy really is protective. And then there was another cohort study from the United States that showed that there was a very significant reduction in colorectal cancer and almost a great reduction in fatal colorectal cancer in patients with a normal colonoscopy. So both a New England Journal and a JAMA publication that really support the fact that normal colonoscopies are protective and we can actually extend the interval between normal colonoscopies. The Norwegians have a wonderful database, as you know, of all of their patients that are ill, and they also had 40,000 subjects in their adenoma resection group that were followed, and they noticed that fatal colorectal cancer was decreased significantly in patients with low-risk adenomas as well as normal patients. So they brought into the concept of perhaps we should be looking at these low-risk adenomas and categorizing them more closely to normal colonoscopy than the patients that had more than 3 adenomas or had high-risk features. And then there was a follow-up study from the US sigmoidoscopy study. You may remember there was sigmoidoscopy screening done as part of the prostate cancer study group that showed that patients that had adenomatous polyps that were detected had a higher incidence of cancer and they should be followed, whereas those that had very few polyps detected or with low-risk adenomas had a very similar to normal flexible sigmoidoscopy incidence of cancer. So again, supportive evidence for this. There's also international evidence coming from the United Kingdom And their large study published in Lancet Oncology showed that those who had a very small 1 or 2 adenomas more than 10 millimeters were actually at higher risk and did better with surveillance than those that didn't. And then there was a group of studies that have been published now showing that there's really a key importance in the quality of colonoscopy that we're performing. And these all were added into the current guidelines. So there's certainly the post-hoc analysis that showed that colorectal cancer is eliminated or protected with colonoscopy, but that if it does occur, it's often because of lesions missed at baseline. And there was then the Kaiser Permanente experience of endoscopists with low adenoma detection rates had much higher rates of interval colorectal cancer. There was showed that as you improve the adenoma detection rate in a population, the incidence of interval colorectal cancer declined. And there's data showing that incomplete resection of polyps is probably very important in the recurrence of adenomatous polyps or colorectal cancer. And these are the references for all of those studies that have been published. And this was very impactful in the formulation of the guidelines that we have before us now. Now, just to show that it's not just the multi-society US task force that has developed this bimodal or low-risk, high-risk approach to polyps and surveillance, this has been accepted by the European Union guidelines, ESGE, the British Society of Gastroenterology, and the Japanese Society as well. So all of the societies have agreed that having 1 or 2 small adenomas without high-risk features is very similar to having a normal colonoscopy. Now, if you look at the old recommendations, we were starting to move in that direction where the suggestion was that you should have 10-year follow-up if you had no polyps detected at your colonoscopy. But if you had 1 to 2 small adenomas, you would recommend to have a 5 to 10-year follow-up. And most of us assume that would be a 5-year follow-up and would schedule our patients for 5-year follow-up. And if you had a higher grade adenoma, a larger adenoma, or multiple adenomas more than 2, we would have our patients come back in 3 years. The current guidelines have really just been an adaptation of that. We still recommend a 10-year interval if you have a normal colonoscopy, and the evidence to support that is actually quite strong. There was a move to actually move 1 to 2 small adenomas to 10 years, but this was fraught with some challenge from the societies and from some of our clinical groups because there was concern that we perhaps were not ready to make that big of a jump. So the compromise was that they would give us a date range or a range of recurrence or surveillance after 1 or 2 small adenomas with low-risk features, and that was going to be 7 to 10 years. And we'll talk a little bit more about that later in the talk. For 3 to 4 adenomas that were less than 10 millimeters, we were in the 3 to 5 year range where we've expanded that a little bit more than just the 3-year cutoff. However, I think most of us are going to follow the early end of the surveillance period, and I'll explain to you why in just a little bit. The rest of the adenomas were at 3 years, with the exception of if you were found to have more than 10 adenomas on a single exam, and there's some data that suggests that maybe even 10 adenomas lifetime, you should have more frequent follow-up, and they're suggesting 1 year follow-up if you have 10 on a single exam. There's also very good evidence, as Swati referred to, that if you have significant adenomatous polyps or early age adenomatous polyps, you should certainly consider genetic testing or at least screening for genetic possibilities. And finally, we're still saying with piecemeal resection of an adenoma more than 20 millimeters, you need to have an earlier follow-up exam. The guidelines had moderate evidence that supported a 6-month interval for that examination, and that's currently what most of us are doing in clinical practice. Now, this is depicted in this graphic very clearly that we have to have high quality colonoscopy first. You have to have complete exams and excellent adenoma detection rates, as well as complete polyp resections. And then you can risk stratify your patients by the type of polyps that you've identified according to this slide. And I'll show you a little bit later how I've modified this. The multi-society task force also made recommendations about serrated polyps. As you know, this has been a bit of a muddy area over the past 5 to 10 years in terms of how do we deal with sessile serrated polyps or true sessile adenomas. And I will say that this guideline doesn't make this much clearer for us. If you look at the right columns, almost all of the evidence is of very low quality and it's weak. But that nonetheless, they have made a statement that essentially reflects the fact that hyperplastic polyps in the rectum and sigmoid are probably of very little, if any, risk. So even if you have 20 hyperplastic polyps in the sigmoid or sigmoid colon or rectum, you should be doing your surveillance at 10 years. If you have hyperplastic polyps in the far right colon, beyond the sigmoid colon, it should still be likely a 10-year follow-up. And there's debate about this because of the difficulty in your pathologic interpretation of hyperplastic polyps versus sessile serrated polyps. Larger polyps should be followed up at a more frequent interval. And if you have truly identified sessile serrated polyps that are less than 10 millimeters, that should be in 5 years. Though there's some move to try to move it to 10. And again, if you have 3 to 4, that should be in 3 to 5 years, and then everything else is pretty much 3 years, except for the piecemeal polypectomy, which is again at 6 months. And I think this pretty much follows what most of us are doing in clinical practice at this time. So what does this mean for your practice in terms of what you have to do? Well, clearly, excellent colonoscopy preps are essential. We're very much inclined with using the Boston Bowel Prep score, which is the preparation of the colon after you've had a chance to clean and aspirate any residual feces or water. And you should really have a perfect examination and be able to see lesions that are less than 5 millimeters in size. If you're not getting good bowel preps, and you should be using split dose preps, some of the newer prep materials may be beneficial. I think having the staff involved with calling your patients and making sure that they're following the prep. Many of us are using some of these automated services and different setup companies that actually will actually call the patients and remind them of their prep. Is essential, because if you're not getting a good prep, you unfortunately cannot make these surveillance recommendations to your patients. You should check the prep before the procedure, and if it's not good, avoid the procedure. Tell the patients that they're going to have to re-prep and come back. And if your prep you do look and your prep is inadequate to detect 5 millimeter polyps, we really recommend that you have the patient undergo a 2-day prep and have a colonoscopy repeated as soon as it can be scheduled, because they essentially haven't had a screening exam if you can't see the mucosa well enough to exclude 5 millimeter polyps. Now, you also should show that your adenoma detection rate is greater than 30% in men and 20% in women. You should be monitoring your adenoma detection rate if you're an endoscopist, and if you're not doing that, I would highly suggest that you do so. And if you're having difficulty getting your adenoma detection rate above 30% in men or 20% in women, you should consider additional training, either hands-on training or some other things that you can do to increase your adenoma detection rate. Some individuals like to use distal tip attachment devices, which have been shown in some populations to increase the adenoma detection rate by spreading out the colon folds and allowing you to visualize the colon. There's going to be additional support with artificial intelligence and computer-assisted diagnosis in the next couple of years that will be very helpful for some individuals that have a low adenoma detection rate. And I say some individuals because really these techniques are not helpful. AI and computer-assisted diagnosis are not going to be helpful if you're not using a good colonoscopy technique to examine behind folds and all areas of the colon. They'll only alert you to what your camera or your endoscopic image shows. The key is really seeing all of the colon mucosa. So you need to work on retroflexing, you need to work on pushing the folds aside and making sure you get a good look at the mucosa to be certain that there are not adenomatous polyps that you're missing. I don't think anyone would question the completion to cecum rate of 95%, and I suspect all of us who are doing colonoscopy can achieve that. Certainly, your practice should require appropriate photo documentation of that, whether it's appendiceal orifice images, TI images, or the ileocecal valve. If you're having difficulty getting to the cecum 95% of the time, you really need to get help, and whether that's with a proctor or with additional courses to help you understand how to reach the cecum in almost all patients. And finally, complete polypectomies is another major issue. in terms of recurrence of adenomatous polyps, particularly if we're going to allow patients to go for longer periods of time between interval colonoscopies. So you should have a very good polypectomy technique with definite margins around the smaller lesions. And if you're removing larger lesions, you should certainly understand all the principles of using thermal therapy and lifting substances and other agents to make sure that you have a complete resection when you remove these lesions. So when I look at this graphic for the actual surveillance guidelines, you have to have high quality colonoscopy, and your practices need to contribute towards that. And then once you've achieved that point, you can look at the intervals and determine how you're going to follow up your patients. This is going to require a pathologic review of the specimens, so you need to have good quality pathology as well. And if you're concerned about the pathology services that you're using, you need to question that. I would suggest that we just simplify this instead of having a range for patients, which I find to be relatively elusive and confusing to them, is to use the lower end of the interval for your patients. I think that's reasonable considering the changes that we're already making and pushing the colonoscopies out. And we will have much more supportive evidence as we go forward another 5 to 10 years that this is a reasonable thing to do. So 10 years for a normal colonoscopy or only hyperplastic polyps. 7 years for that very specific category of individuals that have 1 or 2 adenomas that do not have any high-risk features that are less than 10 millimeters. And then 5 years for those that have sessile serrated polyps that are less than 10 millimeters in size. Everyone else falls into the 3-year category. And then the exception to that is the greater than 10 adenomas, which would be followed up in 1 year. That simplifies it a little bit. It essentially gets us into 4 different recommendations, and those can be very specific. Now, the guidelines also made recommendations for second surveillance endoscopy, not the first surveillance. You already seen the recommendations for those, but this is after you've had the first surveillance endoscopy done. And at the first surveillance endoscopy, you actually again find polyps. What recommendations are you going to make to your patients? The only thing that's specialized about this is if you look at those with high-risk adenomas, those are at the very bottom, adenomas greater than 10 millimeters or have abnormal histology, or if you have more than 5 to 10 adenomas less than 10 millimeters, your first interval surveillance would have been in 3 years, but they're recommending that you don't go to the 10-year interval, that you stay at 5 years for these patients because of the obvious high risk, since they've now formed additional polyps between the interval exams, and that they should stay at this level likely indefinitely. Obviously, with additional data, as we get more experience, we'll be able to better characterize this population, but for now, this is where we stand. The other 2 groups of patients basically follow the standard data that was already presented in the surveillance guideline. The last thing I wanted to talk about is what about your patients that had a colonoscopy before the 2020 guidelines and they're due for their interval colonoscopy now? Are you going to follow the 2012 guidelines or are you going to follow the 2020 guidelines? According to the publications and to the societies, it's acceptable to follow the 2012 guidelines and bring these patients back at the 5-year interval for 1 or 2 adenomas that are less than 10 millimeters in size. It's also reasonable to follow the 2020 guidelines if you want to intervene and tell your patient that no, they can wait 3 more years before their colonoscopy. It's unclear to me how the insurances are going to behave with this recommendation. Currently, we've not had any patients that have been refused colonoscopy based on the 2012 guidelines, but they too will likely adapt, and hopefully they will move the new guidelines into play after 2020. And so your patients with colonoscopies after March of 2020 really should follow the 2020 guidelines, and you should make clear notes of that in your charts and in your procedure reports. I'd like to again remind you that we're going to have the 2nd annual Dentist Day On and Lectureship on Friday, October 23rd. It will be performed during our grand rounds time at 7 a.m. But as Swati mentioned earlier, we will be recording this lecture and making it available to everyone. And as you probably do know, Rick Bolin is a very good friend of Dennis, and it was Dennis's request that he give the 2nd annual lecture. He's currently a professor of medicine at the University of California, San Diego, and he's going to be speaking about Lynch syndrome and beyond, a very up-to-date and interesting review of hereditary colon cancer. I'd like to thank you very much for your attention. And again, I'd like to thank all of you for staying with us and for the organizers for putting together what's a wonderful meeting. Thank you.